Hello, my dear students. How are you? We're going to start the central nervous system, and we're starting with a chapter called hypnosedatives. The name appears a bit strange because I have joined two words, hypnosedatives. If you want to split it up, you can call them hypnotics and sedatives, or you can call them sedative hypnotics. Both these words always go hand in hand. You don't separate them because, as we discussed on the introduction of the central nervous system pharmacology, it's central nervous system depression. And we already discussed all the stages of central nervous system depression, in which the first one was sedation, and that's only quietening, after which you get drowsiness and then you get sleep. Then the deep sleep, then delirium, anesthesia, stupor, semicoma, coma, and death. These were the stages of CNS depression, and that's called dose-dependent CNS depression. I'm just reminding you about it. So what's sedation and what's hypnosis? Sedation is just a calming effect. It's just decreasing the excitement. So sedative is a drug which produces calming effect and which decreases the excitement without inducing sleep. Then you just call sedative. So it's a mild effect. It's a beginning effect. When you talk about a hypnotic is a drug which is likely to produce or maintain a type of sleep which is similar to normal sleep. In other words, hypnotic is a drug which is going to produce sleep or going to maintain sleep, and sedative is a drug which is going to produce just calming or quietening effect and decreasing the excitement. So sedative hypnotics produce general central nervous system depression. But if you give the same drug, what we are talking about, in a low dose, in a small dose, it could produce sedative effect, because this dose is just enough to produce calming and decreasing the excitement. Whereas the same drug, if given in higher dose, could work as hypnotic. And this is why I'm not ready to separate the two words. I've been saying hypnosedatives. The words will be used interchangeably over this particular discussion. Now when we speak of sleep, it's good to know about the sleep waves, which are showing the electrical activity of the brain during the sleep. You can have a look at the slide. There's beta wave, which is low amplitude wave, and its rate is 15 to 35 cycles per second. The next one is alpha wave, is a high amplitude wave, and the rate is 8 to 14 cycles per second. Next comes the theta wave, which is again a low amplitude wave, and the rate is 4 to 7 cycles per second. And the last one is delta wave, which is a high amplitude wave, but the rate is just 0.5 to 3 cycles per second. I have made theta and delta in blue color just to keep in mind that these are the slow waves, and whatever sleep happens with the slow waves is called a slow wave sleep, and that means the sleep is more deeper, which means the electrical activity of the brain is minimal during the theta and delta waves. In addition to this, you can get what's called as K complexes. The K complexes are the deep negative waves which are followed by a positive wave and a few spindles. Now we come to the types of sleep. We usually have the rapid eye movement sleep and the non-rapid eye movement sleep. As you start falling asleep, the stage 0 starts, and then you go to stage 1, 2, 3, 4, and all this is non-rapid eye movement sleep. It's been shown in the slide. The non-rapid eye movement sleep is also called non-REM sleep, non-REM sleep, or non-REM sleep, and this exists from stage 0 to stage 4, and during this sleep we get dreams which are non-recallable. We cannot recall whatever dream you had. These 4 stages complete, and then you're likely to go to the next type of sleep, and that's called REM sleep or REM sleep. That's rapid eye movement sleep. So I'm showing here rapid eye movement sleep, also called REM sleep, and it's called paradoxical sleep, because during this sleep you get the dreams, and you can also recall the dreams. And you can recall the dreams because probably your brain electrical activity was good at that time. So although you are sleeping, your brain is working, the electrical activity is good. That's why we call this REM sleep as paradoxical sleep. Let's split the REM and the non-REM sleep into more stages. So what I'm showing you is the REM sleep, stage 0, is awake, stage 1 is dozing, stage 2 is unequivocal sleep, stage 3 is deep sleep transition, and stage 4 is the cerebral sleep. This stage 4 is supposed to be the deepest type of sleep. Let's come to the third column here, which is showing which waves are likely to present during this particular sleep. When you are awake and your eyes are open, it's predominantly beta waves. When you start closing your eyes, the beta waves change to alpha waves. When you go to stage 1, there are alpha plus the theta waves come in picture. When you go to stage 2, the theta waves are there. In addition, there are spindles. When you go to the next stage, that's the stage 3, you get theta waves as well as the delta waves start appearing. So during stage 3, the delta wave, which are the slowest waves, they start appearing. And during the stage 4, that's the cerebral sleep, there are predominantly delta waves and there are no K complexes also. So stage 3 and 4 are the stages which comprise of comparatively deeper types of sleep, during which you get theta or delta waves, which are slow waves. And this is why stage 3 and 4 is sometimes called slow wave sleep. During the stage 4 cerebral sleep, if you get a dream, you cannot recall a dream. You might get scared, you might get frightened, and you might awake, but you cannot recall the dream. And this type of a dream is called night terror, as shown in the last column. After these 5 stages of sleep are over, you go to the REM sleep. That's a rapid eye movement sleep. We already called it paradoxical sleep. What is this paradox? Because during the REM sleep, you get all kinds of waves, which means the brain electrical activity is good. And this is why if you get a dream during REM sleep, you can always recall each and every minor detail of your dream. This is the stage, the REM sleep, during which the person also gets erection. There are irregular eye movements and the respiration, blood pressure and the heart rate is fluctuating. So that's regarding the various waves and the types of sleep. Why I'm telling you this is, when you start giving a sedative hypnotic drug to a patient, most of the sedative hypnotics, they suppress the REM sleep. The amount of the REM sleep is suppressed. What's the implication of this? The implication is, if you have given this drug for a period of 2 months or 3 months, say, and the drug kept on suppressing the REM sleep, then when you stop the drug and when the patient starts sleeping, all of a sudden the patient gets a lot of REM sleep. That's a rapid eye movement sleep. And because it's happening abruptly, it's called rebound. So please remember, most of the sedative hypnotics are likely to produce REM rebound phenomena when the drug is stopped after long-term use. So that's the importance of knowing the REM and non-REM sleep. What are going to be the uses of hypnosedatives? We'll just have an overview. You can use sedative hypnotic drugs to assist the short procedures. You can use them to produce sedation before anesthesia. You can use it for post-operative sedation. You can use it during the treatment of drug withdrawal, during which the patient is likely to have insomnia. And it's useful also for various anxiety states as well as management of insomnia. So these are general uses, the general description of the uses of hypnosedatives. After this, we will try to know important sedative hypnotic drugs. The first group, as the slide shows, are the drugs which are used for hypnotic purpose, that is for producing sleep. There is diazepam, flurazepam, nitrazepam, temazepam, alprazolam and triazolam. The next group is anti-anxiety benzodiazepines, because many of them have got anti-anxiety effect. And the most commonly used for these anti-anxiety purposes are diazepam, chlordiazepoxide, oxazepam, lorazepam and alprazolam. The next group is the anticonvulsant benzodiazepines, and you have diazepam, lorazepam, clonazepam and clobazam in this group. If you look at this classification carefully, I have highlighted some of the drugs. And if you look at this, at all the 3 places, diazepam is appearing. So it will be easy for you to remember. It's a very important drug. You also see that lorazepam has been highlighted at some places. So you need to remember about lorazepam, and we'll be discussing it in detail. You also need to remember clonazepam, which is an anticonvulsant agent useful in some types of epilepsy. And lastly, I have highlighted alprazolam. It's an altogether different agent. It's a benzodiazepine. It's hypnotic, and it's also anti-anxiety, and it's also useful in patients with mental depression. So that's the first group of hypnosedatives, benzodiazepines. We go to the next group, and that's called the newer agents, or they are called non-benzodiazepines. And an important point to remember about non-benzodiazepines is they have only hypnotic effect. They don't have anti-anxiety effect. I'll come to this issue later, but before that, the names of non-benzodiazepines are interesting. All of them start with Z, is zopiclone, zolpidem, and zaleplon. After this, I'm mentioning one more sedative hypnotic agent, and that's melatonin. That's a hormone inside your body. And one more agent which is related to melatonin is ramelteon. We are doing the classification of hypnosedatives, benzodiazepines, non-benzodiazepines, melatonin, and ramelteon. Now I'm listing the drugs which have the sedative hypnotic effect, but we don't use them commonly for this purpose nowadays. And I'm calling them others. In this others, there is barbiturates. And as you know, barbiturates are toxic agents, and we're not using barbiturates very commonly. There are still some areas in which barbiturates are used in this world. Number one is, it is used as anti-epileptic and anticonvulsant sometimes. That's phenobarbital. And the second important barbiturate is an ultra-short-acting barbiturate. That's thiopental sodium, which is extremely commonly used as intravenous anesthetic for induction of anesthesia and for short procedures. After this, there are antihistamines. I hope you remember H1 antihistamines, that's classical antihistamines, cross blood-brain barrier, and they produce CNS depression. So I need to include them in the classification of sedative hypnotics. The next sedative hypnotic is alcohol, because it's also CNS depressant, and the next ones are opiates. After this, you also see some drugs like chloral hydrate, paraldehyde, bromides, etc., which are not commonly used now. And you have the drugs from other groups for other purposes, like neuroleptics, antidepressant agents, and anticholinergic agents. They can also produce sedative hypnotic effect due to their variable actions on different receptors. Now what I'm trying to say is about a receptor which is responsible for the CNS depression. I'm taking into account three drugs, that's benzodiazepines, non-benzodiazepines, and barbiturates. All the three agents stimulate the GABA, that's GABA A receptor. They stimulate the GABA A receptor. And to remind you, it's a receptor associated with the ion channel, and the ion channel is chloride. What's going to happen is when these drugs go and combine with the GABA A receptor, is going to lead to entry of chloride ions. This is the way the receptor works. Have a look at this slide. It's a beautiful picture showing a pentameric structure of GABA A receptor. You see in the center a beta site, and try to follow me what I'm saying. In the center there's a beta site, I'm showing it to you. Then you move to the right side, there's an alpha site. Then you go back, you have again a beta site. Then you go still back towards the left, you have an alpha site. And the last one is a gamma site. So beta, alpha, and gamma. And you see in the center, I've shown here GABA. So it's meaning that this is the place where gamma aminobutyric acid itself is going to combine. And at the center, you have a channel through which the chloride channels, the chloride ions are going to open, going to enter. Let's draw it here so that it's easy for you, so that you can make an easy picture, an easy diagram, and remember it. Instead of this kind of a picture which you saw on the slide, we'll make it more simple. In the center, I'm drawing a beta. After the beta, we say go to the right side and draw alpha. That's alpha. Then again go behind and draw a beta. Yes. Then go still behind and come to the left side and draw alpha. So that's alpha. And to complete it, you draw the last one here, and that's gamma. So you see a pentameric structure, and the center of the structure is composed by the chloride ions. So this is the channel through which the chloride ion is going to enter to activate the receptor. Now we need to know what's the importance of this pentameric structure. The benzodiazepines and non-benzodiazepines, both of them, they increase the frequency of the chloride channel opening. They increase the frequency of the chloride channel opening. What I mean to say is, when you give benzodiazepines or non-benzodiazepines, the chloride ion channel is going to open more frequently, is going to open more number of times, and this is how is going to produce the transmission. Whereas when you come to barbiturates, the barbiturates are going to increase the duration for which the chloride channel remains open. There's a trend to also call it as lifetime of chloride channel opening. Means when the chloride channel is open once, it's going to remain open for a long time. So I'm saying duration of the chloride ion channel opening is enhanced. Important thing to remember is this: benzodiazepines, non-benzodiazepines, they increase the frequency of chloride channel opening, and barbiturates increase the duration of chloride channel opening. Look at the slide once again. I'm again taking you to the slide. Beta, alpha, and gamma. I want you to concentrate on a site where I have written benzodiazepines, and it's an interface of alpha and gamma. It's an interface of alpha and gamma. That's the place where benzodiazepines are going to act. Let's come to the board and have a look at it. This one is alpha and this one is gamma. So this is the site. Let me use another color for this for you to appreciate. So I'm calling this as the interface of the alpha and gamma. That's the site for action of benzodiazepines. I'll abbreviate the benzodiazepines as BZD. So benzodiazepines act on the interface of alpha and gamma. This particular interface, we can give a special name, and we can call this particular site as the BZD receptor. BZD receptor, meaning by benzodiazepine receptor. This benzodiazepine receptor internally has got two more sites, and the sites are named alpha 1 and alpha 2. You can come back to the slide and see it. The benzodiazepine receptor, the interface of alpha and gamma, is the benzodiazepine receptor, and it's got two sites, alpha 1 and alpha 2. What's the importance? If you combine with the alpha 1 site, most probably you get sedative hypnotic effect. If you're selective for the alpha 1 site, you're likely to get predominantly sedative hypnotic effect. But if you go and combine with the alpha 2 site, you are likely to get a special effect that's called anxiolytic effect, which is independent of central nervous system depression. It's an independent anxiolytic effect. Once again, to revise, alpha 1 site for sedative hypnotic effect and alpha 2 site for anxiolytic effect. What I'm trying to say is and remind you is non-benzodiazepines act only on the alpha 1 site. And if you combine with alpha 1 site, you're going to have only sedative effect and the hypnotic effect. You're not going to have the anxiolytic effect. And this is what I had said while classifying the drugs, that non-benzodiazepines are only sedative hypnotics. They are not anti-anxiety agents. Which are these non-benzodiazepines? A reminder to you, all of them, they started with Z. So I've drawn here 3 Z's to remind you. Check if you could remember the names. Once again, I'm here to help you. Zolpidem, Zaleplon, and Zopiclone. So to end it, the non-benzodiazepines act predominantly on the alpha 1 side just to produce sedative hypnotic effect, and you can't use them for the management of anxiety. They are not used for management of anxiety. Come back to the slide. Benzodiazepines have got effects on both the sides. That's the alpha 1 site as well as alpha 2 site. Alpha 1 effect is going to be sedation and hypnosis. So you could use benzodiazepines for insomnia. And alpha 2 site has got anti-anxiety effect. So you could use benzodiazepines also for management of anxiety. So that's a major difference between benzodiazepines and non-benzodiazepines. Benzodiazepines can be used for management of anxiety as well as insomnia, whereas non-benzodiazepines will be used only for management of insomnia because they only have the sedative hypnotic action. Come to the slide, barbiturates. To make you remember, I have written they act on alpha and beta, both the sides. Wherever there is alpha site and beta site, barbiturates are going to act. All these sites and the selectivity is going to help you to solve many multiple choice questions. Benzodiazepines are important to remember because if you get overdosed with benzodiazepines, we fortunately have a competitive antagonist which can displace benzodiazepine from these sites, and the name of the drug is flumazenil. I would advise you to go back to the general pharmacology last module on which we discussed the overdoses and the toxicities. So repeat, benzodiazepine antagonist is flumazenil. One thing is important about benzodiazepines. If the patient suffers from hepatic disease and if there's a lot of liver damage, the benzodiazepine is not going to be metabolized. And in this situation, the benzodiazepine is going to accumulate and is going to produce toxicity. And you need to take care if your patient suffers from severe hepatic damage. There are exceptions to this particular rule, and come to the slide. In green letters, I'm showing you lorazepam and oxazepam. Very relevant agents when the patient is suffering from hepatic damage, because lorazepam and oxazepam do get broken down in the liver, but they also have another way of getting broken down, and that's called extrahepatic conjugation outside the liver. What I mean to say is, if your patient is suffering from hepatic damage and you give lorazepam and oxazepam, they have a chance to get broken down, they have a chance to get metabolized by extrahepatic conjugation. So if your patient suffers with hepatic damage, lorazepam and oxazepam are going to be comparatively safer agents when the patient suffers from hepatic failure. Next, we go to classify the benzodiazepines based on their half-life. The first group, have a look at the slide, long-acting agents having half-life up to 100 hours. The second group is the agents which have got an intermediate type of effect, the half-life up to 40 hours. And the third one is the benzodiazepines with short action, the half-life up to 2 to 20 hours. The first group, that's a long-acting, contain various drugs, most important being diazepam, chlordiazepoxide, and clorazepate. You come to the middle group, the intermediate acting agents, you have alprazolam, estazolam, lorazepam, and temazepam. I have made this lorazepam blue once again. There are a lot of colors and a lot of relevance to all these colors. You need to remember, and I have done it deliberately so as to make you remember it easily. I have made it blue because lorazepam has got a slow redistribution. It crosses the blood-brain barrier, goes inside the brain, but it doesn't come out fast. It gets redistributed peripherally very slowly, which means lorazepam is going to stay inside the brain, stay in the central nervous system for a longer time. So although we classified it as intermediate acting because the half-life is up to 40 hours, the plasma half-life may be 40 hours, but in reality, this lorazepam stays within the central nervous system for longer time, and this is why many times we prefer to give lorazepam instead of diazepam. The short-acting agents are oxazepam and triazolam. If you look at this slide, there are too many agents which got long action and intermediate action. What's the reason? I would like you to take a look at your general pharmacology, in which we had a chapter where drug is active and gets converted into active metabolite.